So this is about the intubation in septic shock. So we have finished the first part. Coming to the next presentation, which we already been discussed several times on parenchymal problem, which is like severe pneumonia or ARDS. So this is a pediatric table. This is on PARDS. As you all know, grossly, for adults, like it is like ARDS is defined mild, moderate, severe based on PF ratios. I think so. It is like less than 300, less than 200, and less than 100 is severe ARDS. In pediatrics, we follow something called OI, oxygenation index. So mild is 4 to 8, moderate is 8 to 16, and severe is more than 16. And generally, in ICUs, now the pattern is to shift from invasive ventilation to non-invasive ventilation. So that's why there is a terminology called SF ratio, which has come into the new PI ARDS criteria. And based on SF ratio also, the ARDS is classified into mild moderate ratio. So because with SF ratio, you just need the saturation and what is the FaO2 which is going. You don't need a blood gas. So basically earlier there was a thing that you need a blood gas to classify the patient as ARDS. But now even with an SF ratio, which just needs the pulse oximetry and the FaO2 delivered, you need to know. So based on that, you can classify the patient as mild, moderate, and severe. So this has been again extensively discussed. So the pathophysiology is like basically there can be, because of the pneumonia or the infiltrates which is happening in the alveoli, the alveoli are not able to expand. So there is some amount of restriction in expansion. So it can be either due to atelectasis, which is collapse, or it can be due to consolidation. And because of these infiltrate, there is surfactant which is deficient. So because of that, again the alveoli will tend to collapse. So atelectasis, consolidation, and some amount of fluid. All the three components will be there. And there will be areas of normal lungs, which is actually called baby lung. So our aim in ARDS is to protect this baby lung, and whichever part has some areas of atelectasis or fluid, by your treatment, like either it can be in the form of PEEP or by some diuresis or proning, we are trying to ventilate and open up this component of the lungs which are atelectatic and have some fluid. And whichever areas are consolidated, I think we cannot do anything for that. They'll just have to take their own time and try to improve in a while. So because in ARDS, the main component, if you see, is there's something called shunt. So because it is a compliance problem where your alveoli are affected, whatever blood comes here directly goes out here. So there is no oxygenation happening at all. So this is called as a shunt. The blood is just shunted out through the alveoli without having any oxygenation or CO2 issues, ventilation. So this is normal. Here if you see, this is something called dead space, where the vessels are blocked here, air comes in, but again there is no perfusion to this area. This is called VQ mismatch and dead space ventilation. So the main reason for hypoxia in ARDS is this shunting, where the alveoli are completely blocked and there is no gas exchange which is happening here. So because of that, there is hypoxia. So that's why when you give 100% oxygen to a patient, non-intubated patient, by mask, it does not travel through the alveoli into the blood vessels. So when you give oxygenation, 100% oxygen through NRM, and the baby or the adult is not improving in saturation, that means there is significant amount of shunt which is happening, and this is not going to help the patient. So you'll have to resort to positive pressure ventilation. So PEEP is the only thing which will help in opening up the alveoli. All these alveoli will be opened up because of PEEP, and after that there is gas exchange which can happen. So the main things to remember is ARDS is a heterogeneous lung disease. So it can be normal alveoli, which is considered as a baby lung, which you are trying to protect. And there can be alveoli which are filled with fluid or collapse or consolidation. The fluid and collapse we are trying to open up by instituting PEEP. So because of which there will be reduced compliance. And as I already discussed, compliance is reduced, so the time constant is also reduced. Because the time constant is reduced, you will keep a decrease I time and try to increase the I time. Decrease E time and increase the I time. So how do you identify decreased compliance in ventilator? This, I think, in the ventilator graphics also we have discussed, and in the ARDS session it's been discussed. So basically what happens, this is a volume control mode, the pressure time graph. The maximum pressure is called as PIP. Once you put an inspiratory hold, you get a flattening, which is called P plateau. So that indicates the alveolar pressure. So red line which is shown here, the thing above this is called the trans airway pressure. So this amount of pressure is required for the airway, and this amount of pressure is required for the plateau, which is called as a compliance. So when the P plat is high, that means the increase in PIP is probably due to low compliance problem. So here you can see the P plateau is very high. So that means the increased PIP is probably due to low compliance lung. And ARDS severe pneumonia, as you all know, is again a low compliance state. So this is again a graphic. This is called a PV loop. I think you are aware of this. Pressure on the x-axis and volume on the y-axis. So suppose you assume this is 10 of pressure and you have a tidal volume of 100 on the top. The pink one you can see and the green one here. Obviously, whichever is close to the y-axis, vertical is a very good compliant lung because you need lower pressure for a good tidal volume. But in the green, if you see, I think the pointer doesn't work here. So if you see the green graph, the green is sloping towards the right side, that is moving close to the baseline. So that means you need a higher pressure, and despite giving a higher pressure, you end up generating only a very low tidal volume. So that is the problem. So in ARDS again, you get a graph something like green. So after treatment, if your green moves towards pink, so that means the patient is responding to your treatment and the compliance is improving. So the P plat is one way to identify the compliance. Another way is to identify in the PV loop how the graph is. If it is more towards the right, that means again it is a poorly compliant lung. So this is again a PV loop. Again, this basically a different mode. This is a pressure control mode. Here for the same pressure, you have pink, green and yellow. So in the pink one is a low compliant lung. Because of the same pressure, you get a low tidal volume in the pink one and very good tidal volumes in the green one and the yellow one. So as the patient improves, you can see the patient move from the pink one to the yellow one. So basically, for any patient when you ventilate, the ventilator is not the treatment for the patient. It is just a supportive care. You are just buying time till the patient improves. For example, you're ventilating a patient for severe pneumonia, ARDS, till the duration of, like suppose 3-4 days you ventilate the patient. During that time, this ventilation is just a supportive care where you prevent further injury to the lungs. By that time, you should give you appropriate antibiotic therapy, good diuresis, and other things so that the patient is able to get weaned and be extubatable. So basically, treating the underlying condition is the most important thing. So meantime, you'll have to try to identify what is the condition, whether it's a bacterial pneumonia, viral pneumonia, whatever it is, try to identify it and treat it. So ventilator is not the treatment. So you're going to ventilate a ARDS patient. What is your main goal? Your main goal is, more than improving oxygenation, is to not cause any harm. So VILA is ventilator induced lung injury. The ARDS lungs are very much stiff. So sometimes you may not be able to open them at all. And on the other side, you have baby lungs, which are likely to get damaged by your high volume ventilation. So at one side, you'll have to try to balance this. And at the other side, you'll have to gradually try to improve the oxygenation also. So what are the factors which will precipitate VILI? We are keen to see higher FiO2. I mean, we always want higher saturations. But in ARDS, for severe ARDS, your target saturation is only 88 to 92. For mild to moderate, it's 92 to 97. You're happy with 88 saturation. We don't want 100 saturation at all. If we are giving 100 saturation in the monitor, that means we are overdoing the ventilation because high FiO2 is toxic and 100% oxygenation is also toxic. it will cause absorption atelectasis to the lungs. It can itself cause atelectasis, and sometimes it can also cause rarely seizures because of high FaO2. So free radical injury is one mechanism which is seen. Absorption atelectasis is problematic. So high 100% FaO2, that is high FaO2 meaning more than 60%. So your target always in ARDS to bring the FaO2 to less than 60%. And volume trauma. Suppose you have one volume control ventilation, you don't want high volumes. If you give high volumes, again, you're going to cause, it can lead on to pneumothorax. So that is one problem. Again, barotrauma, high pressures, again, high inflation pressures can cause trauma. Atelectotrauma, this is where PEEP comes into play. So inspiration, expiration, usually the alveoli open up, close, open up, close. To prevent this closure of the alveoli, we give something called PEEP, positive end expiratory pressure, which keeps the alveoli open. So because of this repeated opening and closing of the alveoli is prevented. Because what happens when you repeatedly open and close the alveoli, in the alveolar walls, from there, because of the stretch and compression which is happening, closure and opening which is happening, this releases some cytokines. When these cytokines are released, it causes SIRS, systemic inflammatory response syndrome, and it can lead on to multi-organ dysfunction also. So that is called biotrauma. The most common organ which is injured is the kidney. So first lung is affected, second kidney will be affected. And ARDS as such has a very high mortality rate. When it involves other organs also, the mortality rate almost doubles. So that is why important we keep the PEEP so that this atelectotrauma is prevented and part of the biotrauma is also prevented.